Go.
Welcome to our next session in the AP II lab series. This is the reproductive system. Dr. Milescu and I, Dr. Saviuk, will be guiding you through the various structures and their functions. You will find on your lab shell the outlines that I am going to follow to a great degree. You may have to add some extra information because this is just a general guide, okay? So please be aware that you download the lab outlines to make sure that you see the terminology that we're going to utilize. Number one, we're going to look at the male reproductive system. The male reproductive system, as you can see, is made up of the external genitalia, okay, that is visible in both the female and the male. Obviously, there are differences, but once we eliminate the major differences, the internal structures are, even though not exact, have the same functionality in terms of producing, okay, the gametes. So we start out with the general structures, okay? The external genitalia, okay, made up of, as I'm sure all of us know, the penis, okay, which is a conduit, a passageway. That passageway, of course, is for urine and semen, okay? The male reproductive system is involved with, obviously, from the male point of view, erectile tissue. That erectile tissue, of course, is important for the, sexual act in terms of reproduction, okay? The scrotum. The scrotum is where the testes are housed, okay, or what we call in a general term gonads, okay? This is where we produce, as you can see, the sperm, okay, and the hormones necessary to mature and mobilize. But that's not the whole story, because how do we mobilize the sperm? We mobilize the sperm with fluid, okay, testicular fluid, and accessory fluid from the organs that are involved in maintaining the sperm on their journey to the external arena. Number one, we have the Ductus Deferens. Okay, now the Ductus Deferens originate from our seminiferous tubules to our epididymis, okay, and then they travel up and around to the posterior aspect of the prostate gland. The seminal vesicles are located on the posterior surface of the prostate gland, okay, and in this particular case, they will contribute to the majority of the fluid that is produced. Approximately 60% of the fluid is produced from the seminal vesicles, okay? The prostate gland itself produces a fluid and various enzymes, because what happens is on the journey that the sperm take from the epididymis through the Ductus Deferens, okay, to then the seminal glands, okay, the prostate gland, the urethra. What is happening here is the fact that we have the migration, okay, that will now allow for that semen to mix with the sperm and travel through the urethra. Okay? Epididymis. is where the sperm mature. Seminiferous tubules are where the sperm develop. Okay? I think we're good.
Yeah, the seminiferous tubules are inside the testes, and the epididymis sits on top of the testes. Just so you know, it sits superior. So this way you can delineate and differentiate the difference with where do they develop and then where do they mature.
And we will see this in the next few slides. Here we see the gross, sagittal view of our reproductive system, the male reproductive system. So here, as you can see, we have the bladder, the bladder. And let me reiterate, when I stated it before, I said it was on the back of the prostate, which in this particular case, yes, it is posterior and superior when we talk about the seminal gland, but it really is posterior, seminal gland, and the Ductus Deferens are posterior to the bladder, When we see the cavern, as I call it, the cavern of the Ductus Deferens, it will join, and this is called an ampulla over here, it will join with the duct of the seminal vesicle to combine and form, as you can see, the ejaculatory duct. The ejaculatory duct. This will then allow for the fluid to mix with the sperm, with the sperm that are traveling down, into the urethra. Here we see another gland, the bulbourethral gland, and this one is found in this region, of the urogenital diaphragm, which is the floor of the pelvis, This is or contains an alkaline secretion to ensure that the pH of the fluid traveling through the urethra is as alkaline as possible so as not to impede or destroy the sperm that are traveling through. They're very fragile.
They sure are.
Very, very fragile. It's a miracle. The whole darn thing is a miracle. Well, here we see the testicles, And as Dr. Milescu mentioned, the testicles are bounded by the epididymis, So here we have head, body, tail, and then we have the sperm that have matured in the epididymis traveling through the Ductus Deferens.
And there's another name as well, so don't freak out if you see it in other books, but vas deferens and Ductus Deferens,
same thing.
Same thing.
Exactly. So we're going to see that migration, production, growth, maturation, and then journey through the Ductus Deferens to the ampulla, to the joining of the duct of the seminal vesicle, together forming the ejaculatory duct, traveling into the urethra. In this particular case, we have three delineations: the prostatic urethra, Then we have the membranous urethra.
Yep, because of this.
Right. Exactly, membranous urethra, and then we have that little tiny region, of the urethra in the the membranous urethra, So prostatic, membranous, coming right through, into the exit. I think we've covered this one. All right.
Little tidbit here, which will crack you up. I always like to mention this. Upon ejaculation, the sperm are traveling 120 miles an hour. So I'd like to know the scientists
that measured
that. Anyway, I thought you should know.
A little aside.
Yes. Not on any test, but just interesting. I find it fascinating.
So now here we look at the scrotum, okay? The scrotum, of course, is where the testicles are housed, okay? And so here is the way the testicles are separated internally into what we call septas, okay? Now, what is a septa? A septa is a division, okay? Compartment. And there are numerous compartments in here where these seminiferous tubules are producing the sperm. And when I say producing the sperm, these sperm are now migrating, okay? They're growing, okay? So that we had mitosis and meiosis, and now what happens is they are ready to travel. They're very immature, okay? They move up into an area called the rectae testes, okay? Now, you'll read that this is a tortuous area, okay, because there are many different avenues. They then go to the efferent ductules. And if you remember the term efferent, away
For exit, yeah.
okay, they're exiting. And now they go to the epididymis. And remember, the epididymis is where the sperm mature.
And when they graduate, they get a tail. The
That's right.
flagella.
Exactly. Now, there are two terms here that I don't have on my outline, but I always talk about, because we see this in boards and in exams.
That's true.
What is the Darthouse muscle and the Cremaster muscle, and why are they important? Well, let me explain. The Darthouse muscle is smooth muscle, okay, that surrounds the testicles. And as you can see, this is where it is located around the region, okay? All right, the Darthouse muscle right here, all right? Then between the Darthouse muscle and the Cremaster muscle, you see superficial fascia. So this is the connective tissue that is connecting them. Now, the important part about this is that being that this is smooth muscle, it causes wrinkling. The Cremaster muscle is an extension of the internal oblique muscle. These are fibers that travel into the scrotum, and what they do is they are sensitive to temperature change. So when there is a tremendous amount of cold, you're on a ski slope, okay, or you go into cold water, well, what happens is it wrinkles and pulls closer to your body. Why? Because the sperm have to be maintained at a particular temperature that is slightly below body temperature, but it is, if with the body temperature decreases, these need to be maintained within that range, and so the testicles are able to accommodate.
And in extreme heat,
Well,
they get sacrificed.
goodbye. Okay, they definitely get sacrificed, is right. Okay, and those are the main parts that we need to remember in terms of the terminology.
All right.
Okay, so that brings us to our next one. Okay, and here again, just a review. Seminiferous tubules produce the sperm. We now travel to the epididymis to mature the sperm, and as you can see, we have the head on the superior aspect of the body, and then the tail. And from the tail, they are now graduating. They're developing some tail, okay?
Got their graduation hat.
And bam, they are now
Traveling the
through
world
the vas deferens or ductus deferens.
to the magical egg.
Exactly. So here we go.
All right.
Next
Next
one.
slide.
All right, and here again we have, as I say, a lateral visualization of a cadaver specimen in terms of some of the structures. Of course, in this particular case, see, we can see the cremaster muscle here, all right? That is an extension of the internal oblique muscle, okay? Here we have the epididymis, and obviously we cannot see the seminiferous tubules because this is not a cross-section or a, what do you call it?
Sagittal.
Sagittal
Yeah.
section.
Yeah. Inside is the factory making center for
Correct.
sperm. The
All right,
Next
what do we got
slide.
here? Well, here is another one that is just going to show us, again, the cremaster muscle covering, and we're going to see some, you know, parts here that you're going to say, wow, this is a repetition, okay? Some of these things you need to repeat so that you can remember them.
And see it from different viewpoints.
Oh, yeah.
Sagittal versus, frontal.
And then, of course, here we see the spermatic cord, okay? The spermatic cord, which is the avenue that is utilized by the Ductus Deferens to travel superiorly and posteriorly in terms of the bladder. In this particular case, as you can see, we also have arteries in this region, we have nerves in this region, we have veins in this region. Now, the veins are called the pampiniform plexus, okay? Pampiniform, okay? Now you're gonna say, well, why is that such an important aspect? What happens, again, remember we talked about temperature. Temperature below body temperature. Well, blood coming through an artery is traveling at high velocity. This causes increased friction. That friction produces heat. Well, as you can see, you have the artery coming down, okay, and the veins surrounding the artery, which carry deoxygenated blood away from the testicle, okay? And so what happens is this hot blood is being cooled by the cooler venous blood, okay? Does everybody understand that?
Mm-hmm.
Just to make sure that you get that orientation. All right. Again, the same thing that we just saw a few minutes ago. To review, the urinary bladder, remember the orientation, okay? And so here we see the testicle, the epididymis head, body, tail. From the tail, we are now producing, maturing, mature, or traveling through the vas deferens, ductus deferens, to the ampulla of the ductus deferens to join with the duct of the seminal vesicle. The seminal vesicle, now they combine to produce or form the ejaculatory duct. The ejaculatory duct then travels through the prostatic urethra into the membranous urethra.
And out it
Okay.
goes. Yep. Next.
Anything else?
I think that's it for that one.
Exactly. Okay, again, here we see the urinary bladder and how the ureters are coming in on each side, okay?
It's a good posterior view.
This is excellent. The ductus deferens, two tubes coming in, okay? Here we see the ejaculatory duct via the ampulla of the ductus deferens and the duct of the seminal vesicle. And once all of these combine, they combine into a single ejaculatory duct that then goes through the prostatic urethra, through and into ultimately the membranous urethra. Again, I'm not going to spend a lot of time on this aspect, but it's just another visualization of all the parts.
Making sure you know all the glands. So seminal gland, prostate gland,
Bulbourethral.
Those are the three that you need to know.
Also called, if you see this in the literature, Cowper's.
Yeah, that's an old term.
Cowpers, Cowper's glands. Okay?
And
Now
which
you're gonna
one?
see-
This one lowers the pH, right?
pH, correct. The seminal vesicles, just to give us an orientation, nourishes the traveling sperm.
Glucose.
Okay? This is where we have fructose. This is where we have vitamin C or ascorbic acid. Okay? This is where we have coagulating enzymes. I'm going to say coagulation. Well, what happens is the journey from the epididymis through the ductus deferens and to the ejaculatory duct, okay, where the seminal vesicles, as you can see, are going to be nourishing these sperm. They coagulate, or as I consider it, a pit stop. This is the pit stop at the Daytona 500. Okay? They're getting gas, they're getting new tires, the whole thing is getting prepped for
The long
now
journey.
the migration. Okay? The prostate gland has anticoagulating enzymes and activating enzymes. Okay? And this now activates the sperm. And this is the pit crew pushing the car forward. Okay? And now it's to go in an unimpeded path through the membranous urethra. We have the bulbourethral glands making sure there is no obstacle in the way.
And that's the racetrack. And
Exactly.
exiting at 120 miles an hour.
Yeah.
It has a long journey once we go over the female reproductive system. Long journey to get to that egg.
So now we look at the penis itself. Okay? The penis itself anchors via the root. Okay? Via the root, as you can see in both these cases. All right? And so what happens, without getting into too much technical anatomy, this is made up of the erectile tissue. Okay, now in this case, I see the erectile tissue. There are two bands, one on each side. This is the corpus cavernosum, and the urethra, the membranous urethra, spongy urethra, is surrounded by the corpus spongiosum. The terminal end, as you can see, is the glans penis. Okay, the glans penis. All right, and so in this case, at the most inferior aspect, we have the external urethral orifice.
So
Okay,
this portion, the corpus spongiosum, allows for expansion.
right. Expansion, this is the cavernosum allows for erection. Okay?
Okay, next slide.
Again, here we're looking at a sagittal view, as you can see. Okay? Here I have the root, where we anchor this to the body wall, the body, the shaft itself, the neck, the prepuce is the foreskin. Okay, the glans penis is the bulbous end, okay, and then the external urethral orifice, okay. Again, penile urethra over here, okay, penile or spongy urethra, okay, and the membranous urethra at the urogenital diaphragm, and then of course the prosthetic urethra. Kruger, we don't need to get into.
I guess you can talk about the artery, the main artery in the penis. That would be the central artery.
And this one, of course, when we talk about arteries themselves, the blood supply is the major factor that will allow for erection to occur. Okay?
Yeah, so somebody with diabetes or hypertension, issues with their circulation is definitely going to have issues here as well.
Exactly.
Yeah.
Or individuals that are on any type of beta blockers or ACE inhibitors for heart disease or blood pressure. Again, that affects the blood flow and consequently impedes the process of the erectile tissue expanding. Okay.
Cross section.
Cross section again. Okay, we can see the artery. Look at the significance of this in the center of each of our cavernosa. Okay, and here we have the spongiosum surrounding the urethra. Okay, and here we see the layers, the skin, the dermis, etc. Not that we're going to be looking at that, but the bottom line is we see that network of elastic tissues that allows for the expansion of the erectile tissues. Okay, and as you can see, we're good. The deep arteries that I wanted to just reiterate. Okay, next.
All right, next slide.
Next, again, just another reiteration of how the penis is oriented in terms of the structure. And you can see this is like the shaft is lying within a groove, okay, surrounded and protected. Corpus spongiosum, corpus cavernosum.
There's the pelvic floor. Okay.
Another one, I don't think we need to get
Yep.
into any
And just
great
remember
detail.
that the scrotum, is the sac basically that holds the testes, and inside the testes we have the seminiferous tubules, where of course the sperm are being spermatogenesis, the production of sperm.
Exactly.
Meiosis is taking place there.
Here we have sperm, and as you can see, what's the difference between sperm and semen? Okay, what is semen composed of? Okay, so here we can see, okay, seminal vesicles, 65 to 75%, prostate gland, 25 to 30%, and then the bulbourethral, approximately 5%. Okay.
And then this is the anatomy of the sperm.
The sperm has the head, okay, with an acrosome, all right, and what's that important for? This acrosome contains hydrolytic enzymes that are going to allow for the penetration
Through the
of
egg.
the egg, okay? The midpiece is the engine,
Mitochondria.
mitochondria, loaded in here, okay, that drive the tail, okay? The tail is whipping, as we already know in most cases. All right, what do we have here? Pathway of sperm, which we have talked about. Okay, well, let's just review. It's being produced in the testes, okay, and then travels from the testes, seminiferous tubules, via the rete into the efferent ductules, into the head, the body, the tail, through the Ductus Deferens. Okay, here's the inguinal ring, superficial deep. This is part of our spermatic cord. Okay, this then travels up and around to the posterior aspect of the bladder, where it joins with the duct of the seminal vesicle to produce the ejaculatory duct, traveling through the prosthetic urethra, okay, then into our membranous urethra, into our penile spongy urethra, and ejaculation to the exterior.
Okay, so did you want to show them the model, and then I'll be discussing females. So here's the reproductive model of the male. In 1 second. I guess you can detach, yeah.
Somebody.
There we go.
Jeez. Okay.
All right.
So here you can see what we were discussing.
You can bring it closer to the screen.
A few minutes ago. Okay. Where you can see the bladder, the prostate gland. Okay. We go to a posterior view. Here is the seminal vesicle. here they're trying to show us the bands of muscle going through the spermatic cord, okay? And in this particular case, the Ductus Deferens is coming around, joining with the Seminal Vesicle, migrating into the prostatic urethra, the prostate gland, joining with the what do you call Ductus Deferens, as I mentioned before. I've said it so many times.
Also known as vas deferens.
Vas deferens. So these two join together. Okay, the ampulla of the vas deferens right here. You can see this in the posterior view. And I will have on our, what do you call, class shell, lab shell, some of these models so that you can look at them a little closer. And then we have the joining with the seminal vesicles to produce the ejaculatory duct. So here you see this tiny,
that's good.
Tiny little depression going into the prostatic urethra. From the prostatic urethra, it's going through the urogenital diaphragm, the membranous urethra, going into the spongy or penile urethra to exit, okay? And in this particular case, we really don't get a good visualization of the bulbourethral glands, okay? On this particular section, they give us this tiny, I'm bringing this really close, right over here, okay? Representation of a bulbourethral or Cowper's gland, okay?
Very good.
And now I'm going to let Dr. Milescu explain
the female. All right, thank you, Dr. Saviuk. Don't trip. All right, so I'm going to be talking about the female reproductive system. Hi, I'm Dr. Milescu. And I will start with saying that, yes, the breasts are part of the reproductive system. We'll begin first with the pelvic region and talking about all the external parts and internal parts. So the external parts that everyone is aware of is the labia majora and the labia minora. So the outer lips are called the labia majora. The inner lips are called labia minora. Minora means minor and major, majora. Because obviously, if you look at it gross anatomy-wise, the outer lips are much larger than the inner lips. Why do we have that? For protection. And why do we have pubic hair? Again, for protection. So now we're going to take a further look inside. But before we do that, let's just see what all these lines are pointing to, these structures, and identifying what they are. So the first thing that you see here, this is the uterus. And if you look at the structure of the uterus, and it kind of looks like a bull's horn here, okay? That is the female reproductive system because you can see the whole body of the uterus. We're going to go over the parts of the uterus in a moment. And then we have the ovaries, left and right ovary, okay? And then we have the old terminology was fallopian tubes. Now we don't call them that. We call them uterine tubes. We will go over that in a minute. And we have these extensions called Fimbriae that receive the egg during ovulation. Only one egg comes out, maybe two if you're really fertile. But usually day 14, one egg comes out and the Fimbriae receive it. And then it goes to the uterine tube and stays there waiting for the sperm. So we're going to go over that next. So let's take a few more views. And what do we have here? This is a sagittal view of the female reproductive system. So let's go over all the parts. So first off, I mentioned externally what you see. What you see externally is labia majora, outer lip, and then the inner lip, labia minora. Now, the clitoris is erectile tissue that is equivalent and analogous with the glans penis or the penile head. And that also has erectile tissue. So the clitoris basically is there to provide blood supply reaches there, and it allows for an increase in fluid so that there's less friction upon coitus. All right, so let's go over what else do we see here. The first thing that you notice is the difference between the uterus and the bladder. Do not mix those up. It's important. Yes, they kind of look the same, but they're not. So if you look at the uterus, it's completely different structure. The urinary bladder is made up of transitional epithelium, if you remember back in AMP1. Now, the uterus is kind of like a U shape, and some women have a retrograde and anteverted uterus, so the position varies. It's not always leaning anteriorly, sometimes it leans posteriorly. Does it cause trouble? It may or may not sometimes with fertilization. But watch what happens. So we have, this is the urethra. It is much shorter than the male urethra. And in the male urethra, you remember, both the semen and the urine, so it was a urogenital system, was together. Here, it's more than one button, so it's a more complex system here. So that the urethra is anterior to the vaginal canal, as you can see here, okay? So the urethra is anterior to the vaginal canal. And so as the vagina, it's a long route to get to the uterus, and the base of this uterus right here, as you can see, that's called the cervix. So this is where pap smears take place when they put in a probe that is metal and cold and painful. They scrape some cells here to make sure that there's no abnormality, no abnormal cell growth, which can determine whether you have cervical cancer or not. So that is basically the main parts. One more time, here's the urethra, okay? Much shorter than the male. Here's the urinary bladder. To reiterate and go back to what we talked about before, here's the clitoris, very much anterior to everything, and labia majora minora. Now watch, we have 3 openings here, so make sure you know the most anterior opening is the urethra. Just behind there is the vagina, and then you've got the perineal space. Okay, so at some point when a woman gives birth, sometimes an episiotomy is needed, so a cut is made across to allow for birth to take place, because as you know, this whole vaginal canal has to expand to at least 12 to 14 centimeters. Scary, huh? And here's the rectum, and that goes off to the digestive system. Now let's take a look at the structure where the egg is forming. There are multiple eggs that each month one egg is ovulating and matures and is released. Okay, so who receives it? These finger-like projections called the Fimbriae. And then it goes to this uterine tube, which also it has an old name called fallopian tube. And so you've heard of ectopic pregnancies can occur. What is an ectopic pregnancy versus a normal pregnancy? Well, normally, okay, fertilization takes place at the uterine tube. But the fertilized egg is not allowed to stay there. It travels and implants. So implantation of a healthy pregnancy is along the wall of the uterus. If that fertilized egg does not move, that's an ectopic pregnancy. As you can see, that would be terrible tragedy because the uterine tube could rupture, massive bleeding, it's not a viable pregnancy, and it also puts the woman at risk. Okay, so I think that's it with this. I'll keep going. So this is a frontal view. That the previous slide was a sagittal view. So the uterus has, to me, it looks like angel wings. They really are quite broad. So therefore we call this the broad ligament, okay? So this kind of puts everything together. It holds the structures together, the structures of the internal portion of the reproductive system for the female together. And so you can see the body of the uterus, and inferiorly, you're going to see the cervix, as you can see right here. And then the cervix basically leads to the outer opening, the vaginal canal, all right? Now, these ligaments are very strong ligaments, the ovarian ligaments. And unfortunately, I had personal experience with this because if you have what's called ligamentous laxity, if you're an individual that's very flexible, it's not only external, like if you can do this with your elbow. Yes, so this is ligamentous laxity. That is also internal, which is not good because this is overstretched, and guess what happens? Torsion of the ovary. Very painful. It can happen in males as well, but torsion of the ovary can strangulate the ovary, and usually over time it reverts back to its normal position. If not, it requires surgery. That I thought I would mention that as a side note so you understand why the ovarian ligament is very important in holding things in place if it's too stretched out, okay? And that, like I said, is genetic, collagen, and someone who's born with ligamentous laxity. So those are the ovaries, okay? So in here, once a month, an egg comes out, okay? So then what happens? The Fimbriae, which are the finger-like projections, and they really do look like fingers, multiple alien fingers apparently, and it receives the egg, and like I said, here at the uterine tube section, this is where fertilization can take place. The sperm, as you know, has to travel all the way to here in order to fertilize the egg. And then once the fertilized egg travels, it implants in the uterus for 9 months. All right, so let's keep going. So this is just an internal structure of the uterine tube, analyzing it and looking at it further. Note that it is huge. It is so important to have blood supply here, for obvious reasons. And the blood supply is extremely important so that there's nourishment for the development of these eggs, okay? So this is pretty much the same as before, just showing you the structure. Here's the Fimbriae, the ampulla, which is the opening, and this is the narrowed area. So in this region is where we have fertilization. Would you like to point to something?
Well, fertilization is, according to literature, the ampulla is where 90% of all fertilization occurs.
Yes, it can go further, but
Right.
then it would not be a healthy.
Exactly, exactly. So this is where the fertilization occurs, giving time for that fertilized egg to travel down the isthmus and implant in the prepared uterine lining.
Which we'll talk about when we do the menstrual cycle.
Exactly.
Because the uterine wall has to be thickened by a hormone called progesterone. And I always like to say P for pregnancy, because progesterone is really the hormone that prepares the uterus. It really brings more thickening and blood supply to the area. All right, anything else you want to add?
No, this is great.
All right, so there's one more thing I want to add. The uterus has three important layers that you should know about.
Right.
The outermost layer is called the perimetrium, as you can see right here, directly receiving blood supply. And the next one is the muscular layer, smooth muscles. So when someone has menstrual cramps and pain, it's because we're sloughing off that inner layer called the endometrium. Every 28 days, that endometrial layer is going to slough off because there was no pregnancy, so we start over. And the myometrium is what is smooth muscle and causes contractions and therefore cramping in the area. And it's all hormonal when all the hormones drop, which is called premenstrual syndrome, when you feel the drop of the hormones.
The other thing I might add is that the myometrium is contracting during that period. Okay, why? Because what caused the endometrium to slough off, okay, like an avalanche, is that the blood supply to that region has now decreased. There is lack of oxygen, okay, and it is that lack of oxygen that is purported to cause that spasticity, okay? And it's termed Mittelschmerz.
Yes, Mittelschmerz, yes.
In German, Mittelschmerz
Yes.
means pain in the middle,
Yeah.
Okay,
And some people feel it, some people don't. So it is highly variable.
yes.
Okay, so this is going to just show you the regions of the uterus. And yes, we separate it out into regions. So the superior portion is called the fundus. The body of the uterus is really very important. That's pretty much where implantation takes place. Anywhere along that body is where implantation takes place. And then we have the inferior portion. This whole inferior region is called the cervix, which has an opening leading to the vagina. I think that's it with this. Don't forget the broad ligament holding everything together, and don't forget we have other ligaments that also connect the ovary, right? The ovarian ligament, the suspensory ligament,
which attaches the broad ligaments to the lateral body walls. Okay, there's one other one that is important, is the round ligament.
yes, which I believe was a couple of slides. Let's go back. Do we see it here?
No, it wasn't.
No.
It wasn't evident as yet.
Okay, it's coming
It
up.
should be
It's coming up.
There it is.
There it is. Yep.
The
Round ligament. Okay.
Now you notice that has its own heading.
Yeah, it's pretty important.
And the reason for that, okay, just to reiterate, well, not reiterate, but to mention, is the fact that the round ligament will maintain the uterus in its anterior position.
Yeah.
Now, how it does that is kind of bizarre, because what it does, that ligament attaches all the way into the labia majoris.
Yep.
Okay?
So those pelvic floor Kegel exercises, that's what we're working on to strengthen and support the soft tissue structures, so that after giving birth, a lot is stretched out, obviously. So doing the Kegel exercises and pelvic floor exercises, which I highly encourage, will support the uterus. And as I mentioned before, sometimes the position gets altered, and it happens after multiple births. Yes.
Then
Okay.
it becomes more difficult in terms of
Testing too.
testing, and
Yeah.
the other thing too is if this ligament for some reason is compromised, and we now have a retrograde,
Yeah.
okay, what happens is it straightens out.
And then it could slide down.
And that's what happens.
Yes.
Is if impregnation, okay, and you're hoping for fertility to be displayed. The unfortunate thing is if it's standing up this way,
Can't happen.
it doesn't happen.
Yeah.
The egg falls out.
Right. And then furthermore, as you get older, which, after multiple births, like let's say you had 3 or more kids, it's no longer in its correct position, and it's very, very easy for it to herniate out.
Exactly.
And I don't even want to talk about those issues. They come out through the vaginal canal sometimes, and surgery is emergent for that. Okay, I think that's it with this image. We'll keep going. All right, so again, just reiterating what we talked about, the round ligament, the broad ligament, and the suspensory ligament. Make sure you know all three, okay, and their location and what their purpose is for. Okay, so obviously the suspensory ligament is going to be very much near the ovary, supporting that. The broad ligament is broad for a reason. It's got the angel wings. It pretty much holds everything together. Yep. And then, as Dr. Saviuk said, the round ligament is extremely important because it wraps around behind inferiorly and literally holds the pelvic floor together, going all the way down inferiorly. All right. The rest is pretty much, you can see that this is the uterus. The top of it's called the fundus, then the body, and then the inferior portion is called the cervix. And you can see how when someone has a colonoscopy, if they mess up, there's also this around. So, surgery is very important in the pelvic region. Especially in the female, it's very complicated. So hopefully have a good surgeon. Yeah.
You don't want surgery.
Yeah, no, if you need it.
Yeah.
All right, so the rugae here. So these are the ridges, and you're going to see all the way up the vaginal canal. And here's the hymen, and this is what, if you've never had intercourse, the first penetration, the hymen breaks, but they say that if you are a female that exercises, it ruptures anyway.
Exactly.
Yeah. So this is the opening. It's called the vestibule. So it's the direct opening from the outer world. As you know, the labia minora were the smaller lips, and then the outer lips are what's visible externally. Just like in the male, you can visibly see the scrotum holding, housing the testes. All right, so let's keep going. So this is a view of the external portion of the vagina, so you can see exactly what's going on. So these are the equivalents, as I said, the prepuce. You can think of the equivalent of the foreskin in the male, okay? And the clitoris is the equivalent
the erectile tissue?
of the erectile tissue, yep, in the glans penis, okay?
The labia majora is the analog of the scrotum.
Yes.
Okay, so you get an orientation of some of the, what you call differentiations, because when fertilization occurs and initially the, what you call embryo is growing, the embryo has two sets of sexual counterparts, Mullerian and Wolvian, okay? And depending on the signal, the genetic signal, one of them will degenerate, producing either a male or a female. When they do not, then we have a hermaphrodite. Okay, they have both sets.
Yeah, so a hermaphrodite would have both sets, but not fully formed.
It's not going to be fertile.
No, and not even fully formed.
No.
Sometimes the penis is not even fully formed.
Exactly.
Yeah. Okay, this is the perineum, the space between the vagina and the anus. And this is the section that women, if needed, and the head is too large when the baby's coming out during giving birth, it either tears on its own or the doctor will cut it, okay? It's best that you cut it because then it heals faster, stitches and all that. All right. Have I scared you from having babies?
Here we are. This is what we were talking about.
Okay, so this is exactly what Dr. Saviuk was talking about, the analogy between, in terms of the structures, the analogy between the male and the female.
Exactly.
All right, so let's see, let's take a look here. You see the uterus, and you can see the testes. All right, what else do we see here? All the same structures that I've already mentioned, the similarities and the differences.
Right. But again, this isn't something we're going to get into.
Yeah, this is quite detailed.
Yeah, it's too detailed for what we need in terms of the profession we're going into, unless we're going to work with a reproductive scientist or a medical doctor.
Yeah, so I'm just going to keep going, but you can study this PowerPoint on your own time, along with your lab outline, so that you can at least be able to identify all the structures, okay? And we went over everything here. The things that I would highlight on the female end is make sure that you know all the 3 ligaments, as mentioned before, know where the fimbriae are, know that that's, where fertilization takes place, okay, in the uterine tube, or also known as fallopian tube, the broad ligament holding everything together, the ovary, right? The cervix, you had the fundus, the body, and the uterus, with the fundus, the body, and the cervix. And then you've got the vaginal canal. I would also reiterate that you should know where the clitoris is in reference to the urethra, which is anterior to the vagina, which is anterior to the anus. Okay. So, in this analogy, you can see, as Dr. Saviuk mentioned before, the scrotum, and there it is. labia majora, okay?
Okay.
And then if you look at the raphe of the penis in pink here, and then labia minora, and there's the raphe here.
Right.
So it's identical,
And
the
then if
same
you're looking
cells.
at the body or shaft, again, body of the clitoris.
Yep.
Okay, here you have the glands, what do you call clitoris?
So the clitoris is a miniature
Glands,
version.
penis, exactly.
Yeah, it's just a miniature version of the glands, penis here, and
Here's
body.
the prepuce.
Yep.
Okay, the foreskin, as we stated.
To cut or not to cut?
Yeah.
That is the question.
Exactly.
So there's lots of evidence now recently that's more discouraging, whereas in the past it was more encouraging in terms of cutting the prepuce. Still personal choice and of course personal faith.
Exactly.
All right. So we get to the breasts, which it's not about the looks, it's about making milk.
That's exactly correct.
So what the structure looks like, we have here lobules, and the nipple is what the baby latches on for the milk. And the male also, male and female both have the areola, male and female both have the nipple, but the difference between the male and the female is that the females will have these lobules, and we have surrounding the area is fat, and we have hormones that cause the production of milk, which we went over our last session. There was the initial let out of milk, and that was oxytocin.
Production
Yep.
of milk.
And then production of milk, and continuous production had to be a continuous stimulation at the nipple by the baby latching on, so that prolactin is going to initiate the continued production of milk.
Exactly.
Yeah. All right, so that's it about that. I guess we'll end with talking about some contraceptive ways if you are not planning on having a baby. And then I'm going to end with the menstrual cycle, because it's really important, whether you have a baby or not, to know your body and know the menstrual cycle. If you're a female, that is. Okay, so the male condom is effective, but yes, there are failure rates, and there are different materials that are less satisfactory if you want to use it as contraception. So latex is the best to prevent pregnancy and sexually transmitted diseases. The worst, I would say, is sheepskin, because it's highly porous and you may get pregnant. Whoops, what did I just do? Uh-oh, there we go.
You're good.
All right, now, the next one here, this is plan B. So let's say you think you had unsafe intercourse and you might be pregnant. This is the day after pill. It's called the plan B one step, but it needs to be taken no more. It has to be taken within 72 hours, okay? And then of course there's the oral contraceptives. You could take the pill, or you can get the shot. So whichever one, there's many choices. And then we have various implants, you know, we could talk about, but the best thing is, if you don't want children at all, it's a quite simple procedure. In the male, it's actually easier than the female procedure. You go in, and there's the Ductus Deferens, also known as the Vas Deferens, and basically it is cut and tied off. So now you're going to ask, well, what happens during ejaculation? The semen is still released, same amount, except minus the sperm.
Right.
So it can't cause any pregnancy. So that's what a vasectomy is. And yes, a vasectomy in most cases can be reversed if the father determines that he wants to be a father again.
Right.
In the female, though, it's all or nothing. Once we tie it off, that's it. Now, you could tie off both, or you can tie off one. If you tie off one, you're still at risk for getting pregnant, if that's, you know. All right, so basically here you can see where that's where fertilization takes place, at the uterine tube. So this whole area, also called the fallopian tube, is again cut and tied off. So let's say you ovulate, the fimbriae receive it, it's going nowhere. It's going nowhere. Bye-bye.
unless it reverses by itself.
Yes, not happening. All right. So the last thing I'm going to talk about, which is extremely important, whether you're pregnant or not, just trying to understand your cycles so you can work around it. You don't want any surprises. That's for young people, right? When you really don't know, like young girls, when they first get their period, they don't get adjusted into their cycle, and that can lead to accidents and not being prepared for the bloodletting. So let's go over it. So here's what happens. So day 1 to day 14. So this shows you, this is a graph. Day 1 to day 14. Let's go over what happens day 1 to day 14. So the first thing that happens is there's a slow increase in body temperature, and there's a surge right before ovulation. That's neither here nor there. I want to talk about mainly the hormones. The first 2 hormones that are important to follow the first 14 days are luteinizing hormone and follicle stimulating hormone. And you know that these come from the anterior pituitary, right? You remember they come from the anterior pituitary. So follicle stimulating is going to develop the egg, okay, and cause ovulation. Luteinizing hormone stimulates the production and increase in estrogen, okay? So these 2 are slowly coming up, and on day 14, if you're like clockwork, day 14, the surge takes place. What surge? The surge of luteinizing hormone, much higher than follicle, but both surge at day 14. Now, at the same time, we've got estrogen playing. So simultaneously, that's why females are complex. We've got FSH and LH surging on day 14. Between 12 and 14, depending on the female, between 12 and 14, estrogen starts to surge. And there are stories about estrogen rage. It does change your behavior. But yes, right before, between day 12 to 14, estrogen surges. During this time, simultaneously, your uterine wall starts to thicken. All right, and day 14, the egg is released. Boom, there it is. The egg is released, the fimbriae receive it, and if everything's going well, it's going to go to the uterine tube. Okay, what happens after day 14? LH and FSH suddenly drop. Boom. Over the next couple of days. So day 15, 16, 17, LH and FSH drops. Estrogen drops dramatically as soon as you ovulate. And then what happens is the hormone for pregnancy goes up. And that hormone is called progesterone. Now take a look. Right around day 17 to 21, okay, we've got progesterone peaking. And the second estrogen peak also occurs. So this is that one more shot before pregnancy where the progesterone hormone, P for pregnancy, right? Progesterone hormone really assists the uterine wall in thickening and preparing it for pregnancy. And like I said, both estrogen and progesterone do a second peak between 17 to 21. And then by 28 days, everything shuts down. 28 days, progesterone drops, estrogen drops, FSH and LH have already dropped a long time ago, so everything drops. That's what contributes to day 25 to day 28 PMS. And then, of course, the sloughing off is the menstrual cramps. So, to review without looking at the chart, what should you remember? Day 1 to day 14, FSH and LH is slowly coming up, and then there's a huge surge, as you can see here. LH pops up, FSH not as much, but both surge. Estrogen right before day 12 to 14, there's a surge, and then the egg comes out day 14. Anywhere between 12 to 14, 15, that's when the egg comes out. Great. Then what? Then progesterone peaks, then estrogen peaks right afterwards, anywhere between 17 to 21. And then 21 to 28 is a whole slow dip, and a big dip causes the PMS, premenstrual syndrome, where progesterone and estrogen drops. And once progesterone and estrogen drops, we've already had FSH and LH leveled off. Everything's low now. And when everything is low, that causes the behavioral changes. And then finally, the uterine wall sloughs off. And that's pretty much it. You want to add something to it?
The only thing I want to add is we always talk about negative feedback and positive feedback.
Yes.
Okay? Negative feedback, we know. Okay? When something is high, we want to bring it low. When something is low, we want to bring it back up to a higher level, to a normal level. Well, in this particular case, as Dr. Milescu pointed out, estradiol, estrogen, peaks. Okay? Why does it peak? Because what happened was the initial growth that was occurring, okay, between day 1 and that maturation up to day 12, 13, whatever that may be, okay, maybe even day 10, 11. We don't know. But the bottom line is that was initiated by estrogen, okay? Well, as the follicle and the estrogen that was being produced by the growing follicle caused a negative feedback. The negative feedback shut down the further production of FSH because we were now growing the follicles. But in that growth process, what was happening? The follicle was producing what? More and more estrogen, which is this surge. Well, what happens is, why did I need that surge? That surge now went back to the hypothalamus, sent the signal to the hypothalamus to say, and the anterior pituitary, I now need LH.
So LH peaks next.
LH peaks, okay? Does FSH still come into play? Slightly. None of these are independent. Everything works together, but at this point, as Dr. Milescu was saying, that estrogen peaks. Why? Because that is the positive feedback to say, LH, pour out. And the LH now prepares that ovarian wall for the rupture that allows, and see here you can see, this is the ovarian wall that is rupturing to allow the mature egg to be released.
And some women that are very body conscious and aware of their body and their mechanisms can actually know when they ovulate. They can feel that pain during this rupture. Some do, some don't.
And the key is here, it's like someone was here, my students so often say, what do you mean it's rupturing? I say it's like popping a pimple.
Yes.
Okay? When you pop a pimple, sometimes, no big deal. Other times you go like, wow, it's got a head, and you press it, you go, oh my God, I got a shot into my eyeball. You know what I'm saying? Because what's happening? Nerves are being, irritated.
Yeah.
They're being affected. And so consequently that pain, you go like, but that egg is so tiny. But the wall of the ovary is quite thick.
Yeah.
Okay? So these are all little factors that we don't take into account when we're looking at this. And as I say, this is, compared to the male, this is a complicated process that the female goes through.
Speaking of complications, I will never forget this. So in my residency, I don't know if Dr. Ragassa is still out there alive, but I paid tribute and homage to him because he explained something that was very interesting to me, and I still talk about it in class. And you're not responsible for it. It's just something to know if you want to have children. Apparently, fertilization, if you have intercourse before day 14, you're more likely to have a female. And if you do intercourse, say, days 16 to 28, you're more likely to get a male. So why is that? They found that statistically to be correct. Apparently it has everything to do with the pH of the vagina. So as the progress of this whole menstrual cycle occurs, if intercourse occurs way later after ovulation, yes, you can still get pregnant. The pH of the vagina is more, get this, alkaline. All right? And so you're more likely to have a boy. If you are going to have intercourse right around or before ovulation, the vaginal wall, the space, the pH is going to be lower. And so that acidic environment is going to kill off the XY sperm, the Y sperm, so that when the XY comes in, it's not going to get to the egg, is what I'm saying. The Y sperm will die off, and it's not going to get to the egg, so you're not going to have an XY. You're going to have an XX. So more X sperm are going to be traveling during that time. So statistically, you're most likely going to have a girl. Interesting.
Here we go.
And that's pretty much all I have to say. Do you have anything else to say?
Just, look over these PowerPoints, okay? And feel free to send us any information that you may have been confused about or would like explanations in the future. Thank you.
Thank you for watching. Bye.
Bye-bye.